Hello, Dr. Pritchard and dear classmates. My name is Adam Chaudhry, and I'm a student nurse practitioner. Today, I'll be presenting an adult patient case involving a pulmonary complaint seen in the clinic this week. So, identification and chief complaint. This is a 64-year-old male who presented to clinic with a chief complaint of shortness of breath and persistent cough for approximately 2 weeks. So, the history of present illnesses, the patient describes the cough as a dry, non-productive cough, and it gradually is worsening. He reports the cough was present throughout the day, but is not noticeable at night, and it was interrupting his sleep. He also reports shortness of breath with exertion, especially when he was climbing stairs or walking longer distances. He states that prior to 2 weeks ago, he did not experience breathing difficulty with normal activities. He denies wheezing, chest pain, fever, chills, nasal congestion, or seasonal allergy symptoms. He denies recent travel, sick contacts, changes in medications, or exposure to occupational irritants. He tried over-the-counter cough suppressants with minimal relief. He denies history of asthma or recurrent respiratory infections. Past medical history includes hypertension and hyperlipidemia. He denies having diabetes, coronary artery disease, prior pulmonary disease, or past hospitalizations for respiratory complaints. His current medications include lisinopril and atorvastatin. He also reports here that he has medication adherence. He denies known drug allergies and reports no history of hospitalizations or surgeries. He is up to date with his influenza vaccine, and he has not received pneumonal vaccines this year. Family and social history. Family history is not significant for lung disease, COPD, asthma, or cancer. Social history reveals former smoker, and he smoked with pretty much 20 packs, a 20-pack year history. He quit smoking approximately 5 years ago. He does drink alcohol socially. He denies illicit drug use. He reports no current occupational exposure to chemical fumes or dust. The review of symptoms. So we went through reviews of his symptoms, and he is positive for cough and exertion dyspnea. He denies weight loss, proximal and nocturnal dyspnea, night sweats, orthopnea, leg swelling, or fever. So his vital signs upon exam. So his blood pressure was 148/88. His pulse was 92 beats per minute. His respiratory rate was 22 breaths per minute. His temperature was 98.2 degrees Fahrenheit. His oxygen saturations were 93% on room air. And upon physical exam, he appears alert and is in no acute distress, though he becomes slightly winded during long sentences. A pulmonary exam reveals diminished breath sounds bilaterally with expiratory wheezes throughout the lung fields. No rhonchi or crackles are noted. His cardiac exam shows a regular rate and rhythm without murmurs. No jugular vein distension is present. There is no peripheral edema, cyanosis, or digital clubbing. His HEENT and lymph nodes are normal. There is no sinus tenderness, post-nasal drip, or oropharyngeal inflammation. So his diagnostics performed today was a chest x-ray. It was obtained in clinic and shows lung hyperinflations with flattened diaphragms consistent with chronic obstructive lung disease. There are no infiltrates, consolidations, or effusions. So, a point of care spirometry demonstrates a reduced FEV1 slash FVC ratio, confirming an obstructive pattern. So his differential diagnosis is here. My differential diagnosis includes number one, COPD with acute exacerbation, acute bronchitis, late onset asthma, community acquired pneumonia, and or heart failure related to dyspnea. Given the spirometry results, chest x-ray findings, smoking history, and absence of infectious symptoms or fluid overload, the most likely diagnosis is newly diagnosed COPD with a mild exacerbation. So my final diagnosis here was that he has COPD, mild exacerbation, newly diagnosed. So the treatment plan here includes, short-acting bronchodilators. So I would say that he would need albuterol inhaler, 2 puffs every 4 to 6 hours, PRN for shortness of breath and wheezing. Long-acting muscarinic antagonist, so like something like totyrapam, 18 mcg inhaled daily. Maybe a short course of oral corticosteroids such as prednisone 40 milligrams daily for 5 days. A full pulmonary function test and an alpha-1 antitrypsin level will be ordered for disease severity, staging, and hereditary risk. I also think vaccination counseling is important. Annual influenza vaccine, pneumococcal vaccine per CDC guidelines. Lifestyle education, so like correct inhaler technique was reviewed with the patient, activity pacing with breathing strategies discussed, reinforcement of continued smoking cessations plans, and the patient will follow up in about 2 weeks. We also told him to come back if it starts, if it includes worsening symptoms, increased shortness of breath, wheezing, anything like that. So that concludes, my visit with this patient. Thank you for taking the time with me to go through this patient case study. And I, encourage any questions in the discussion board. Thank you, Professor, and thank you, dear classmates, for taking the time. Have a good night.